أعزائي الطلبة، السلام عليكم. Our lecture today will be about the exocrine pancreatic function. In this lecture, we will have many important objectives. The most important objective is to list the component of the pancreatic secretion, and then we will describe the type of the pancreatic enzyme and the function of each of these enzymes. In addition, we will describe how can we use these pancreatic enzymes as a marker of disease since they change their activity will change in disease of the pancreas. So we can correlate clinically between the change in the level of this enzyme with the disease state of the pancreas. The pancreas is composed of both exocrine part and endocrine part. The endocrine part is responsible for the production of important hormone. Example is the insulin, which is very important as an carb or glucose lowering enzyme. And we have the glucagon, which is also important in carb metabolism. We have also the pancreatic polypeptide and other hormones that are produced from the endocrine part of the pancreas, while the exocrine part of the pancreas, which is the subject of our lecture today, will secrete mainly an alkaline fluid, which is rich in bicarbonate, and this bicarbonate make it alkaline, and this fluid contain important enzymes that are very important for the normal digestion. The pancreatic fluid usually pass from the pancreas, then it will pass through the pancreatic duct to the common bile duct, and then it will pass to the duodenum. The pancreatic fluid, because it is alkaline, contain bicarbonate, it is alkaline, its pH reached to about 8.3. So this alkalinity is very important to neutralize the gastric fluid that come from the stomach, and the stomach contain the HCl, which is acidic. High concentration of HCl is found in the gastric fluid. So when it passes to the intestine, to prevent the harm that may be caused by this high acidity, the pancreatic fluid, which is rich in bicarbonate that make it alkaline, will neutralize this acidic fluid. So the pancreas composed of an endocrine and exocrine part, and also it can secrete the fluid, which is about 1.5 to 2 liters per day. The fluid is clear and colorless, and it is rich in enzyme, which are digestive enzyme, and is important for the metabolism of fat, carb, and protein. And this is the function of the enzyme, while the function of the bicarbonate-rich fluid from the pancreas is to neutralize the HCl from the stomach. The enzymes that are secreted from the pancreas usually are many types, but we can divide them into enzymes that digest the protein. We call them proteolytic enzyme, which are the trypsin, the chymotrypsin, the elastase, and the collagenase, the aminopeptidase. All can digest a protein, and they are called proteolytic enzyme, and this is the first class of the pancreatic enzyme. The other class of the pancreatic enzyme are the lipid digesting enzyme. Example of these, and the most important, is the lipase, the colipase, and the lecithinase. These are lipid digesting enzyme: lipase, colipase, and the lecithinase. And we have the carbohydrate digesting enzyme from the pancreas, which is the amylase, which is a very important enzyme. And we have other enzymes, for example, the nuclease. Example of the nuclease is the ribonuclease that split the nitrogen base from the sugar phosphate strand. So it is important for the digestion of the RNA and DNA nuclease. These pancreatic enzymes, together with the pancreatic fluid, within the pancreatic fluid, are poured into the second part of the intestine in the duodenum, and the bulk of the intraluminal digestion usually occur distal to this site. So the digestion and the use of these enzymes occur distal to the second part of the duodenum. One question is whether these enzymes completely digest the all nutrients that come from the stomach. The answer is no. It cannot completely digest it. It usually converts it to a smaller molecule that can be acted by intestinal enzyme later on to make them ready to be absorbed by the intestinal cell. So the pancreatic enzymes are very important for digestion, but usually in most cases it do not digest them completely. They need another step, which is the digestion by the intestinal enzyme. So the pancreatic enzyme complete or partially complete what has been done in the stomach, and their action will be completed by the intestinal enzyme. So it will convert the material, the digested material, into a simpler form. We have these enzymes, the amylase from the pancreas, which act on the carb, and we have the protein, trypsin and chymotrypsin, and on the oil, lipase mainly act on it. The first enzyme, which is very important, is the amylase, which is carbohydrate splitting enzyme or carbohydrate digesting enzyme. It is a hydrolase class enzyme, and it is responsible for the hydrolysis of the 1,4-glycosidic linkage of the polysaccharide, whether the molecule is a straight chain carb or branch chain carbohydrate as glycogen. Both the straight chain carbohydrate or the branch chain carbohydrate, both amylase can act on them, and the amylase usually need calcium for proper action. It is a calcium metalloenzyme, and one of the important features of the amylase that it is not specifically found in the pancreas. It is found in other tissue. The main tissue that contain amylase is the salivary gland in the mouth, and the pancreas is the other major source. So we have the two major isoenzymes are the P amylase from the pancreas and the S amylase or the salivary amylase from the salivary gland. This means that carb metabolism started by the amylase, which is the salivary amylase or the S amylase from the in the mouth from the salivary gland, and this process started in the mouth by the salivary amylase and continue in the esophagus, but the action of the salivary amylase will be terminated in the stomach by the high HCl concentration. Then after the food come into the duodenum and the alkaline pH of the duodenum, it favors the activity of the pancreatic amylase, and it will continue the process of carb digestion. So amylase will cause hydrolysis of the polysaccharide, convert them into smaller units, which are the maltose, dextrine, or glucose, and these molecules will pass later to the intestine. So we have two types of the amylase, or more than two types, but the main isoenzyme are the S from the S amylase or salivary amylase from the salivary gland, and it will initiate carb digestion in the mouth. And we have the pancreatic amylase from the pancreas that also perform the hydrolysis of the carbohydrate and make them smaller units, and its action is favored by the alkaline pH in the duodenum. We have the pancreatic or the P-isoamylase and the salivary isoamylase. The amylase enzyme is a small molecule. It is a small molecule, so it can pass through the glomerular filtrate, and it is the only plasma enzyme that's found normally in the urine. So the amylase, because of its small size, it can pass through the kidney glomeruli, and it will normally appear in the urine. If there is any damage to the glomerular membrane, so that the amylase cannot pass through the glomeruli, it will be retained in the circulation and will lead to a high level of the amylase in the circulation. Amylase is one of the substance or the material that are synthesized by the body, but can also used as a marker of a disease state. So, amylase is synthesized. We have the salivary amylase, and we have the pancreatic amylase, and also it can be produced from other site, for example, from the intestine or from the ovary, but mainly we have the salivary gland and the pancreas. So, when does it increase? Usually the enzyme increase when there is destruction of the cell that contain high concentration of the enzyme. Inflammation of any cell, usually the enzyme is found inside the cell. So if there is inflammation and destruction of the cell wall, this will lead to release of the enzyme from inside the cell to the circulation. And when we measure its concentration in the circulation, it will be high concentration. So because the amylase is found in high concentration mainly in the pancreas and in the salivary gland, so inflammation of the salivary gland will lead to increase in the level of the amylase. And this inflammation is called parotitis. And if we have inflammation or acute pancreatitis, also it will lead to increase in the level of the amylase. Why? Because the inflammation of the pancreas may lead to activation of the enzyme and autodigestion of the pancreatic cell, and destruction of the wall of the pancreatic cell will lead to release of the pancreas from inside the cell to the circulation, and this will lead to high level of the amylase. And usually the isoenzyme that is increased is the pancreatic, the P amylase. We have other causes of increase in the level of the amylase. For example, certain type of tumor, biliary disease also will lead to a high level of amylase. In case of renal failure, because as we said, it is small molecule, the amylase is small molecule that normally pass through the glomerular, the kidney glomerular, and appear in the urine. So in case we have damage to the kidney and the glomerular membrane are damaged, the amylase will not appear in the urine and it will remain in the circulation, resulting in high level of amylase in the circulation. Macroamylasaemia is another cause of a high level of amylase in the circulation. When we measure the amylase, we will find that it is very high. What is the macroamylasemia? It is a condition, a benign condition that results from binding of the amylase with immunoglobulin, usually with the IgA, and when the amylase bound with the IgA, it will form a large complex. This will lead to decrease in the ability of the kidney to excrete it. Why? Because it became a big size molecule. So amylase, when it bind to IgA, it will form a large molecule so that the kidney cannot excrete it. And when we measure the level of amylase in the circulation, we found that the level is high, and it is a benign condition. In reality, it is not increased, but it is retained. It is retained by the kidney because it's bind to IgA, and it will form a large molecule that cannot pass from through the glomerular kidney of the kidney to the urine. In this condition, it make confusion in the diagnostic confusion, because it may be misdiagnosed as with other condition of elevation of the amylase. So we will find many conditions that will lead to increase in the amylase, starting from salivary gland disease to biliary disease, pancreatitis, especially the acute pancreatitis. Renal failure also will lead to increase by retention and not real increase in case of intestinal obstruction, intestinal ulceration, intestinal ischemia, and if we have perforated DU also may lead to increase in the amylase. And in case of ectopic pregnancy, because it is found, the amylase is found in the ovary. So in case of ectopic pregnancy, also it may lead to increase in the amylase activity. So this marker, the amylase, also it is a normal marker that's produced by the body, but by knowing, but it can be used as a marker when we see that its level increase in the circulation. We can put in our mind the differential diagnosis of this high level of the amylase. We have two type of at least two isoenzyme of the amylase. So we can differentiate between the increase in the amylase, whether it is salivary or pancreatic source of elevation, by measuring the isoenzyme. If we find that the total amylase is increased, we cannot pinpoint the site of release of this amylase. So if we do the isoenzyme, we found, for example, that the S or the salivary amylase is increased. In this condition, we think that it is disease of the salivary gland that will lead to increase in the level of the amylase. Otherwise, if the P or the pancreatic amylase increase, we will think of acute pancreatitis. So isoenzyme determination is very helpful to differentiate between the different type of hyperamylasemia. In other conditions, for example, in case of renal failure, we will see that the other marker of renal disease is increased in addition to the high amylase. So we may think that the patient have the increase in the amylase is due to renal failure rather than inflammation of the salivary gland or acute inflammation of the pancreas. So the main causes are acute pancreatitis, glomerular impairment that prevents its excretion, perforated peptic ulcer, and a salivary gland disease, maybe inflammation, maybe mumps, or calculi, maybe stone, that cause obstruction and increase in the level of the amylase. So it is used as a marker. Is it a good marker? It is to a certain extent. It can give an idea about a number of an organ that may be diseased because they are the source of the high amylase, but its problem is that it is not specific. Why it is not specific? Because the amylase is secreted from many organ, not specific to a certain organ. If it is secreted only from the pancreas, so when we found that it is increased, we will see, we can see definitely it is pancreatitis or pancreatic disease in general. But because it is found in other tissue and increase from other tissue, disease of other organ may also lead to increase. How can we increase the specificity of its diagnosis of a certain disease? By measuring other marker together with the amylase, measuring other organ. For example, other enzyme or for example, in case we suspect that it is if the marker of renal failure increased together with high amylase, we suspect that it is maybe due to renal impairment that will lead to a high amylase activity. And in case of acute pancreatitis, we measure other marker, other enzyme that are released from the pancreas, and so on. In case of chronic pancreatitis, in case of acute pancreatitis, lead to release of very large amount of amylase, usually due to autodigestion of the pancreas and release of very large amount of the amylase. But in case of chronic pancreatitis, usually the level of amylase is near normal because the number of cells decrease and there may be fibrosed, so the production of these cell will also of the enzyme will be low. The macroamylasaemia, we talk about it. It is the binding between the amylase and the IgA that prevent renal excretion and lead to a high level of the amylase in the circulation, but it is not due to disease state, rather it is due to some sort of variation that lead to this binding, and because of big size of this complex, so it will lead to decrease in the renal excretion and high level in the circulation. The other type of the enzyme that are secreted from the pancreas is the protease or the proteolytic enzyme. The most popular or the most important are the trypsin and chymotrypsin, and because they are very active enzyme, so they are synthesized as an inactive enzyme, inactive proenzyme, not fully activated, and the trypsin proenzyme is called trypsinogen, and the proenzyme of the chymotrypsin is called a chymotrypsinogen. Okay, so it is synthesized as inactive proenzyme because of their activity. If they are synthesized as active enzyme, then this may lead to autodigestion of the pancreas. So the amylase mainly act on the starch or carb, and the protease on protein, and the lipase on the lipid or the fat. The trypsin, the precursor or the trypsinogen, the main function is to split the carboxyl side of the amino acid, lysine or arginine, and it will catalyze the hydrolysis of the peptide bond. So it will lead to breakdown of the protein into a smaller peptide, and then it will later on will be hydrolyzed into a small into amino acid by another peptidase or protease. The other proteolytic enzyme is the chymotrypsin, and also it will activated by the enzyme enterokinase in the intestine, and the activated trypsin also will activate more chymotrypsinogen and more of the trypsin. The other proteolytic enzyme is the carboxypeptidase, and this is responsible for removing one amino acid at a time from the polypeptide. After the action of the trypsin, chymotrypsin, and carboxypeptidase, the protein will be converted into a smaller molecule, and the digestion is completed in the intestine, small intestine, by peptidase. Usually, protein digestion started in the stomach by pepsin and is favored by the HCl of the stomach. Then it will be The pancreas will participate by trypsin, chymotrypsin, and carboxypeptidase in the digestion of protein, and the final digestion and absorption occur in the small intestine. So the digestion of carb start in the mouth, stopped in the stomach, and resumed again in the small intestine by the action of the alkaline fluid from the pancreas that is rich in bicarbonate, and by the amylase enzyme. This is for the carb, while the protein digestion started in the stomach by pepsin favored by the HCl, the high acidity in the stomach, and it will also the pancreas will participate by the trypsin, chymotrypsin, and carboxypeptidase. The final digestion and absorption of the protein will occur in the small intestine. Then the other category of the pancreatic enzyme is the lipase, which is important for digestion of the lipids, and usually the dietary fat is triglyceride. Most of the cholesterol is synthesized in the liver, while in the diet we mainly have triglyceride. Triglyceride is acted upon by the lipase. It will break the triglyceride into 2 monoacylglycerol and 2 fatty acids. This pancreatic lipase require the colipase from the duodenum to be fully active, and also require the bile salts or bile acid that are synthesized in the liver. So it requires colipase and requires bile salt. Bile salt is from the liver, colipase. So the digestion of the and absorption of the dietary fat, which is mainly triglyceride, depend on a proper function of both the pancreas and the liver. The liver will synthesize bile salt that is very important for the action of the lipase and for the digestion of the lipids. Lipase also is increased in case of pancreatitis, acute pancreatitis. In case of acute pancreatitis, whatever the pathology, there will be autodigestion and activation of the enzyme, and autodigestion of the pancreatic cell and release of the enzyme. And since both amylase and lipase are found in the pancreatic cell, it means that in case of acute pancreatitis, this will lead to release of both amylase and lipase. And different, each one have a different half-life and different time of rise and fall. So we said to increase the diagnostic specificity of amylase, we will depend on combination of amylase with another marker. Since lipase is not found in the salivary gland and it is found in the pancreas, so in case of inflammation of the salivary gland, parotitis, or salivary gland inflammation, the amylase will increase because it is the salivary isoenzyme will be released, so amylase will increase, but because it contains no lipase, it will not increase. In case of a tumor, also lipase will not increase, only the amylase. In case of biliary disease, mainly the amylase. In case of pancreatitis, acute pancreatitis, the amylase will increase and the lipase also will increase, and this will help in the diagnosis, because if we are not very sure whether the patient have abdominal pain, whether the complaint is pancreatitis or it is intestinal or it's ectopic pregnancy or other conditions, so we can differentiate by amylase with the lipase. So in case of pancreatitis, lipase also will increase, and with ectopic pregnancy, it will not increase. Why? Because it is not found in the ovary, while the amylase is found in the ovary. In case of macroamylasaemia, the amylase increase while the lipase is not increased. So generally, when we measure amylase with other marker, we will increase the specificity for the diagnosis. Other pancreatic enzyme, we have the nuclease that will break down the RNA and DNA into a component nucleotide, and the elastase also would cut a peptide bond, especially in the alanine and the serine. If we want to assess the pancreatic secretion, or how they are secreted. Usually there is a negative feedback mechanism that tightly control the secretion of the pancreatic juice. These we have two types. We have the secretin and the cholecystokinin, and each one have a different stimulatory effect. Secretin mainly stimulate the secretion of the pancreatic rich fluid, and it will lead to increase of the pancreatic flow, and it is released from the duodenum, while the cholecystokinin mainly is for the pancreatic enzyme release. So the secretin mainly for the pancreatic fluid that is rich in bicarb, and the cholecystokinin mainly for the pancreatic enzyme stimulation. How can we check whether the pancreatic function is normal or it is abnormal? We have two general type of tests. We can use either invasive test or non-invasive. What is the difference between them? The invasive test. It means that we intubate the patient and we put a tube. We introduce a tube and aspirate the fluid, and then we will check for the enzyme content and the bicarbonate content of the pancreatic fluid. And usually we stimulate the secretion of this fluid either by giving the patient a meal, or we giving him certain stimuli, and then we put the tube in the duodenal fluid and we aspirate and we measure the trypsin activity, and we will measure the bicarbonate concentration and other character. Either we give him first standard meal or we give him secretin or cholecystokinin, and we measure this marker. Putting a tube in this way is an accurate method, but it is uncomfortable for the patient. Most of the patients refuse to put this tube, and it is expensive and need a long time. So we do not prefer this method. It is not very practical method, although it is very accurate. So we can measure or we use non-invasive tests by taking a blood sample from the patient, and we measure the level of the amylase and lipase, and it can give us an idea about the pancreatic function. So instead of putting we intubate the patient and GIT intubation, and we put instead of GIT intubation and put a tube into the duodenum and aspirate the fluid after stimulation, we can use an alternative method by taking a blood sample from the patient, and we measure the level of the enzyme amylase and lipase, and then we can take an idea about the pancreatic function. Other marker is the fecal elastase. We can take a sample from the feces and measure the level of the elastase, and also we can measure the chymotrypsin activity. They lack the specificity and sensitivity. Why they lack? What do we mean by lacking the specificity and sensitivity? It means that because they are secreted from many organs, we cannot say exactly that the source of increase in the amylase is due to the pancreas. So this is the specificity. We cannot exactly say that this lipase is from the pancreas. It can give us a general idea or can give us a clue, but we cannot make sure that the source is from the pancreas. Sensitivity, what do we mean by sensitivity? It means that this enzyme will not increase until we have severe damage. We may have severe damage in the organ to start in the increase of the level of these enzyme. So this is called lack the sensitivity. A sensitive marker means that it is increased in the beginning of the disease. This is so all these tests that measure the level of these enzymes in the blood, they lack both the sensitivity and the specificity. Usually in case of acute pancreatitis that may occur secondary to a disease, for example, stone, or it may be a mump infection, or it may be due to whatever the cause, or trauma, maybe due to trauma or acute inflammatory response. In all these conditions, it will lead to intracellular activation of the enzyme precursor that are found in the pancreatic cell. This will lead to generation of free radical and acute inflammatory response, destruction of the cell, and release of very large quantity of the pancreatic enzyme to the circulation. The amylase usually increase after 12 hours after the beginning of the symptom, and it will return to normal within 3 to 5 days. If we measure the total amylase activity in the circulation from the blood sample, which will be increased, but we say that it is not specific. We cannot exactly say that the cause is from the pancreas. We can measure the isoenzyme, the pancreatic isoenzyme, so it can be more specific, increase the specificity of the test. Or we can measure with it the plasma lipase, because the source of lipase is also from the pancreas. So if we found that both of them are increased, it means that the possibility that the cause of elevation is from or due to acute pancreatitis is increased. So to increase the specificity and sensitivity, either we measure the isoenzyme of the amylase, and we also measure another enzyme, which is the lipase, which is secreted from the pancreas. So in acute pancreatitis, usually it starts from 2 to 12 hours, but mainly that became detectable or increased usually after 12 hours, it peak within 12 to 72 hours, then it will return to normal within 3 to 4 days. So in case a patient come to you after 3 days, he have acute pancreatitis, but he may present it with acute abdomen, and he have many maybe misdiagnosed, or he may be lately presented to you after 3 days. The amylase in this condition after 3 days, it will start to decrease or return to normal. So you misdiagnose him because of his late presentation, because amylase after 3 to 4 days return near normal. So in this condition, we may choose to use another marker or combination of marker. This is the lipase. We can see that the lipase increase after 4 to 8 hours, and it will peak within 24 hours, and it will remain elevated for 8 to 14 days. So the presentation, or the if we measure the lipase after 3, 4, 5 days, it also remain elevated, while the amylase return to normal within after 3 to 4 days. So it is better for the diagnosis in case of late presentation of acute pancreatitis. We can combine them, or if we, from the history, the patient presented lately, we can depend on the lipase with other radiological and other marker of disease. So if we compare the time elevation and the duration of the elevation of both amylase and lipase, we will find that the amylase duration of increase is less than that of the lipase, and if we combine both of them, it will give a better diagnostic specificity, and also we depend on the time of the presentation of the patient. So if it's presented late, lipase is better than amylase in case of acute pancreatitis. Which test to choose? It is better to combine both of them, lipase and amylase, and also depend on the duration or the time of the presentation of the patient. Because amylase is small and can be excreted normally in the renal and by the glomeruli in the urine, so we can use the urine amylase as a marker of a disease, because if the production of the amylase or the level of amylase in the circulation increase, so the excretion in the urine also will increase. So we can use this marker in two conditions. In case we suspect that the patient have acute pancreatitis, then we can measure the urine amylase because it remained for a longer period than the serum amylase, and this is the first thing. And in case of macroamylasemia, we say that the binding of amylase with the IgA, it means that because of the large size of the complex that is formed by this binding, it will be retained in the circulation and cannot be excreted by the kidney. This means that its concentration will be high in the circulation in the blood, but it will be low in the urine. So in this condition, a urine amylase measurement can give a clue that the cause of the high level of the blood amylase is macroamylasemia, when the urine amylase is low and the blood amylase is high. Other biochemical change that occur in case of pancreatic disease, especially in case of acute pancreatitis, is the hypocalcemia that may be the result from removal of large amount of calcium from the extracellular fluid because of impaired mobilization or as a result of calcium fixation by fatty acid. Sometimes we have hypercalcemia. So in case of in case of pancreatic disease, acute pancreatitis, there may be hypocalcemia or hypercalcemia due to maybe combined hyperparathyroidism. The triglyceride also be elevated in case of acute pancreatitis, and hyperlipidemia itself may be one of the causes that cause acute pancreatitis. So, and usually plasma glucose in case of damage to the pancreas, and the pancreas have an endocrine part that is responsible for the production of insulin. So in case of damage to the pancreas, it may affect the level of glucose and lead to glucose intolerance, may be transient because of maybe edema to the pancreas and disturbance in the function of the endocrine part and the beta cell that secrete the insulin. So in case of acute pancreatitis, we will have the serum amylase increase, the serum lipase increase, and serum calcium. We may have hypocalcemia or sometimes hypercalcemia. We have hypertriglyceridemia and we have hyperglycemia. The other condition, when we have decrease in the function of the pancreas, when we have insufficiency of the pancreas, and because the pancreatic enzymes are very important as an integral part for normal digestion. So if we have defect in the pancreatic production, the digestion also will be abnormal. And this will lead maybe secondary to chronic pancreatitis or CA of the head of the pancreas that will lead to destruction of the cell. So the production of the enzyme that is important for the digestion will be low. In children, other cause is the cystic fibrosis, which is a genetic disorder. One of the marker of a chronic pancreatic insufficiency is the fecal elastase. The fecal elastase is a product of the pancreas. Elastase is a product of the pancreas, and it is characterized by having a high concentration in the feces when we compare it to the concentration in the duodenal fluid. In the feces, it is about 5 to 6 times higher than in the duodenal fluid. So if the fecal elastase is low, it means that the production from the pancreas is low, and it means that we have pancreatic insufficiency, and it is a good diagnostic test. The diagnostic specificity is high, and if we suspect that a patient, usually in patient who have pancreatic insufficiency, he will complain of diarrhea, malabsorption, fatty stool, and bloating, abdominal pain, and gases. So we can, if we found that the patient have low level of the elastase in the feces, it can give an idea that the cause of his condition is pancreatic insufficiency that may be secondary to chronic pancreatitis. This is a case study to test your information. A 35-year-old man went to the hospital. He have abdominal pain suddenly, and he have swollen, painful, and salivary painful salivary gland. The total amylase was 600, and the normal is up to 110 units per liter. So, in this condition, what you will put in your mind about the condition of this high amylase, and to make sure that the source is salivary, what should you do? So this is the question for you. And the other case is a 57 years old man presented to the surgeon with an acute abdominal pain and usually with nausea, and the location of the pain is in the epigastrium. So a blood test was done for him, and we will see that the sodium is normal, potassium is normal, the bicarb is normal, the glucose is very high, the calcium is low, and the triglyceride is normal, the amylase is very high, it is about 10 times the normal. It's about 2,567 units per liter, while the normal is less than 200. So it will be about 9 to 10 times or 8 to 10 times. It is more than the upper normal. So in this condition, we have hypocalcemia, hypertriglyceridemia, hyperglycemia, and hyperamylasemia. So what is the diagnosis and how can this be confirmed? This is the application of how can we use the tests that are or the marker that are normally found in the body. How can be they used as a marker of disease state? Thank you, and ready for any question.